I'm Marta Lobato. I'm a vascular surgeon. I'm dedicated to CLTI and I work in the BTK-BTA unit in the Hospital de Cruces, Bilbao, Spain. I would say that probably calcium is the main issue when treating below the knee and below the ankle pathology. And this is very common in patients with CLTI because we treat many diabetic and in chronic renal disease patients. And in these patients, calcification is very common. And calcification is associated with poor outcomes when talking about revascularization. We have many issues about angioplasty and performing a good angioplasty, particularly because when vessels are severely calcified, we can lead in recoil, dissection, thrombosis, distal embolization, and this is always a very bad issue about outcomes during revascularization. It's probably related to the stiffness of the vessels. When talking about below the knee calcification, this is associated to medial arterial calcification. So when these vessels are so stiff, we had very bad outcomes when performing angioplasty. We need to perform angioplasty under high pressure. And that's the reason why we have these issues. So we need more efficient tools to face against this challenge associated to calcification. And for this purpose, particularly IVL therapy, the Shockwave E8 catheter is very useful to face these challenges with calcification in the below the knee and below the ankle vessels. Well, this was a 76-year-old patient, former smoker, with this disease, as you can see, a common risk factor, high blood pressure, diabetes, dyslipidemia, and chronic kidney disease, which is associated with severe calcification. On the physical examination, femoral and popliteal pulse without distal pulses, non-compressible AVA, this lows TCPO2, and the patient required an urgent debridement when he came to the emergency room. As you see, Wi-Fi classification 333, you may agree with me, high risk for amputation. Well, we went with the patient to the OR, this diagnostic angio, severe disease with calcification at the below the knee segment, with a severe calcification, as you can see, under plan X-ray. We perform recanalization of the posterior tibial artery and treatment with the Shockwave E8 catheter. As you see, we use the catheter in the lateral plantar artery, posterior tibial artery, and we were able to perform the angioplasty with low pressure. And this was a nice completion angio, patency of the posterior tibial artery, lateral plantar artery, as you see in the lateral view, and as well in the AP view. And the most important thing, the patient went well. He recovered posterior tibial pulse, rise in TCPO2, as you can see, 60 millimeters of mercury. He required wound debridement. He was put under antibiotics according to the SWAS, and he was discharged 10 days after the procedure. The patient needed a skin graft, and this was the clinical evolution of wounds. As you see, 15 days after the procedure, we performed the skin graft, and as you see, 40 days after the procedure, the wound was completely healed. The new E8 catheter has become an essential tool in my armamentarium because I need the main challenge we need to face when treating these CLTI patients is calcification. So for me it's essential because it's needed to achieve better outcomes regarding to dissection, distal embolization, and recoil.